Thank you. Ladies and gentlemen, I want to thank you for being able to come here and tell about the Finnish screening program that is now in place. We have an implementation phase of a public health screening policy program, and there are a lot of people involved in the planning and organizing and running this procedure. Even though the main organizer has been the Finnish Cancer Organization, who made this possible by funding. We saw the rates, the incidence and mortality rates in Europe earlier, and even in the States, and these are rates from Finland from late 1950s to 2004. These are not estimates, these are actual figures, but the two last dots are based on annual numbers and the others are 5-year medians or means. So we can see that colorectal cancer incidence is leveling off. It has risen a lot from the 50s in Finland, but it's leveling off now. We are in a stable situation for both men and women. And for mortality, it has not increased that much from the 1950s, and in women it has in fact decreased. The launch of colorectal cancer screening in Finland was done in 2004 in September, and it is a population-based program that we have launched with a gradually increasing implementation phase, so that we increase the target population over time, and we also increase the regions over time. The main aim of the program is to reduce colorectal cancer mortality, as probably most of you already know. And within this program, we have inbuilt the evaluation of the program until effectiveness, until mortality reduction, eventually. We also want to test feasibility during the implementation phase. That is that in Finland we did not launch a special pilot program, but we launched the national screening program with a feasibility phase or feasibility pilot inbuilt in the national program. So I have to show there. Okay, did I miss something? No. So the screening process in Finland, it's based on individual invitation by mail, and our target group is from 60 to 69 years old people, at least in this phase. And we have an individual level randomization during the first 6 years of the program into screening and control groups, so that within each municipality, gender and age cohort, we individually randomize half of the people to screening and half to the control group, who will not receive screening before 6 years. We have the GAIAC-based test kits, 3 test cards for each, mailed to the people that will be screened, and they return the test kits by mail. We also have the results mailed to everybody, disregarding whether it's positive or negative to those that have complied. And we repeat screening every 2nd year. We have no exclusions. And this is the program as a scheme in Finland starting from 2004. We take 3 age cohorts during the 1st and 2nd year of the program in each municipality and randomize them individually, and thereafter rescreen every 2nd year those that have been offered screening, and then the new age cohorts that come into screening age will be randomized to screening or control over the first 6 years of the program in each individual municipality. And then after the first 6 years, we screen also those former controls gradually, so that eventually, after 10 to 11 years of the beginning of the program, the people between 60 and 69 years are covered by screening. So the procedure is a 3-day fecal occult blood test, which is taken at home. It's a GAIAC test, and we don't use any rehydration. Any positive test window out of the 6 is regarded as a positive test, and everybody that gives a positive test will be sent to colonoscopy to the regional healthcare provider. The normal care and surveillance will take place after this. And the data is collected centrally as starting already from the invitation process. The first experiences during these 3 years of screening in Finland, we started with 22 municipalities. In Finland we have more than 400 municipalities, and each individual municipality has to make their own decision to launch, because they also pay for the program. It's included in the public health cost. By this year we have reached 175 municipalities within the program, and so far, and probably also for the future, we would only need 1 screening center for this kind of screening with fecal occult blood testing. Our population is about 5 million people. The 1 center in Finland takes care of all invitation and analyzing of the test cards, as well as data collection and sending referrals and also test results to those complying. Our overall compliance has been good so far, 71%, and the test positivity rate as expected, 2.1%. And this is a picture of our coverage so far. This is Finland, and our 440 some municipalities are shown with these small lines. And in 2004 we launched in 22 municipalities. In 2005 we expanded. The yellow is 2006 and the green areas 2007. So this is expanding over regions. The first round, meaning the first screening round between 2004 and 2006, is comprised of more than 52,000 men and women in both arms, meaning the control arm, which has not been offered screening, and also the screening arm, which has been offered screening. These are based on, as I told, on the individual randomization into screening and control groups. And the test results from the first round. Our compliance has been overall very good. This gives, non-compliers are here, gives a compliance of 71%. In men, of course, well, not of course, but it's less, 63% comply. In women, 78% comply. The positivity rate overall is 2.1% of those that comply. In men, it's 3%, and in women, 1.5%. And the compliance by age, which has been touched here already today, these are the age cohorts, the birth cohorts here that we have been offered screening so far, from 1940 to 1946, those born in these years. And the compliance seems to go down when you get younger. So those born in 46 are more non-compliant than those born in 1940. And these are all offered screening only after they have reached age 60. This is for males, the upper picture, and for females, the lower picture. So overall, non-compliance for males is 37%, but of the oldest ages, only 27 are non-compliant, and in the youngest, more than 40. And for women, the overall non-compliance is 22, and in the oldest ones, 18%, and in the youngest ones, 24%. So this might be also due to some kind of an age cohort. Well, these people born before the war, during the war time, might be different than those born after the war. I don't know. Remains to be seen. We have referred all those that tested positive, a little more than 800 people, for colonoscopy, and these are still preliminary because not all the colonoscopies from 2006 have yet been reported. But so far, among those 800 people, we don't have any diagnoses out of 235, not yet. And of the rest, 660 about, we have already 54 cancers, almost 300 adenomas, out of which 28 are with high-grade dysplasia. Then all kinds of other diagnoses, normal finding in 60 cases. And those that we don't know of yet, we have the information missing from 60 and the information still in progress from 87. Colonoscopy is not done to 88 out of 803 so far, and most of these are because they have been done recently. There are various other reasons ranging from proposed dietary problems and all these kinds of things. Some of these others are in fact declining colonoscopy, but they want to give some other reason for that. Not known, the reason is not known only for 2 people. And those not reached, they are in fact, they have died before colonoscopy could be offered. So as a conclusion, I come back to the evaluation of the process. Our randomized design allows unbiased comparison between the screening and control arms with different aspects, starting from feasibility and coming up to effectiveness eventually, even if it takes a long time, between 15 or 20 years even. We can follow cancers and deaths through national registers. We have Statistics Finland and the Finnish Cancer Registry, which is 100% coverage. Then we can follow the screened and controls as to colonoscopies performed in hospitals and surgery, also through register linkage. For the first 3 years, for example, we are interested in the performance of the program, compliance, positivity rate, how colonoscopies have been achieved, and so forth. And we have planned to cease the randomization after 6 years from launch, and we need to wait an additional 10 years before we can tell whether mortality reduction was achieved in the Finnish program or not. Thank you.